Good morning, everybody. Dr. Chow mentioned my name is Jeff, for those of you that I haven't had the chance to meet yet. And today I'll be chatting about the best practices for imaging cardiac device-related infections and endocarditis. And, I know there's kind of a bit of an endocarditis theme going on with Abdul's excellent presentation last week with cases. But, this talk was inspired by, a couple of things last week. Some of those being that, at the end of Abdul's presentation, I think it's actually Dr. Chow yourself was asking, further questions about, other imaging modalities that could be used in the setting of endocarditis itself. And then the ACC had just published a state-of-the-art review that was released just over a week ago now that was kind of addressing that exact question. So I thought that, this would be a good opportunity to review this, and then we can be all endocarditis out after this. And so even just another thing that was kind of inspiration for this talk was that last week we had a little bit of a case, which I'll just give you a quick synopsis of now. But we had a gentleman, 91, who was admitted to the General Internal Medicine Service with fevers. And he had a history of a bioprosthetic aortic valve replacement and was admitted. His blood cultures grew MSSA, for which he was treated with cloxacillin. The feeling was that the MSSA source was likely from an infected ulcer on his foot, but of course, prudent to do so, wanted to make sure and rule out endocarditis. The TTE was negative, but they had actually referred for a TEE as bioprosthetic material to try to get a better look. And as we know, that TTE can't always rule it out. However, when we tried to do the TEE, there is a lot of anatomic issues with actually trying to intubate the esophagus with the TEE probe, most likely due to a lot of osteophytes in the neck, use 91, and maybe some spondylolisthesis. This is making it very difficult. We tried multiple different techniques, 3 different providers, jaw thrust, and it was just causing him a great bit of discomfort. So we had to stop. And then we kind of left all of us thinking, well, now what do we do now? So hopefully with this talk and kind of approach to, what else can we do if there is some concern that we can't actually do the TEE. So there we go. So in terms of the objectives for the talk, I just hope that we could chat and examine the utility of echo in diagnosing device-related infections. Another imaging modality to review CTs, also in diagnosing these infections, as well as FDG PET. So just some background. So infection is a major complication of cardiac devices, which can actually have quite horrific consequences. Misdiagnosing these cardiac device-related infections is also associated with increased mortality. And of course, overdiagnosing of these infections as well can lead to unnecessary device extractions, increased hospital stay, and mortality. And seeing how involved these device extractions are, that it's actually can be quite a dangerous procedure. Sometimes using laser lead extractions, it's not easy. Not just to forget that it opens them up to whatever conditions that require them to get that device in the first place. And then now, just as our technology is getting better, our patient population is getting older, we're seeing the use much more increasingly of cardiac devices, pacemakers, ICDs, prosthetic valves, as well as LVADs, particularly in the advanced heart failure population for mechanical circulatory support. And as we're placing this prosthetic foreign material in the body, there are also increased rates of device-related infections. And now this, as we're implanting these devices, particularly TAVIs in a much older population, as well as pacemakers, and then as we've aged, this population has become increasingly more comorbid, which is increasing the possibility that device-related infection can be possible. And now, as we know, just as their general approach, as in kind of the vignette that we had talked about at the top, but TTE and TE consider the first-line imaging for suspected infective endocarditis for diagnosis, as well as assessment of some of the complications that can come along with that. However, as many people on this call know, that this can be particularly challenging in the setting of prosthetic material and prosthetic valves. CT and CT angiogram can also be useful for the anatomical assessment of things like paravalvular tissues, fistulas, abscesses, pseudoaneurysms, and can also help with the surgical planning, just to give a sense about the general chest anatomy as well. But with both of these imaging modalities, unfortunately, they are subject to artifact, particularly from metal within these devices. So this is kind of where FDG kind of breaks onto the scene. So FDG is fluoro-2-deoxyglucose, which targets inflammatory cells, such as macrophages, neutrophils, and lymphocytes, at the site of both infection and inflammation. And then what they do is, after you uptake this tracer, is that they look for the FDG signal with positron emission tomography or PET. What's great about this is that PET isn't susceptible to the same kinds of artifacts that CT and echo are, which is quite a big bonus. And also, it allows the early detection of inflammation and early infection before anatomical damage has actually taken place. And now, kind of growing recently, there's been a lot more advocacy for the judicious use of FDG PET, especially when anatomical-based imaging, echo and CT, are inconclusive or equivocal. So just to start first with echo, as this is an echo talk, but one of the best things about echo is that it's great for the interrogation of structural abnormalities, detecting vegetations and abscesses. And also, as you get to see hemodynamics in motion in front of you, you get to see some of the functional consequences, whether that be regurgitant lesions, aortic insufficiency or mitral regurgitation, stenosis, fistula, assessment of embolic risk, ventricular function, as well as secondary pulmonary hypertension, whether it's related to left heart failure or septic emboli. And one of the advantages of echo is that it's safe, very widely available, quick, comprehensive, and it's relatively inexpensive. The probes can get expensive when compared to paying for a PET scanner and radioisotopes. It's the much more inexpensive option. And still, and with all of our guidelines, it remains the first line for detection of device-related infections and prosthetic valve endocarditis. And that's a class 1 recommendation, ACC, AHA, and the ESC. And then built into the framework of the diagnostic criteria itself that we use for infective endocarditis, the modified Duke, it is a major criteria. So its importance can't be understated enough. And then here's an example of just the AHA endocarditis guidelines. As you can see, just following the flow chart, looking at the top, that TTE class 1 indication, green right up front, as being your first test that you should always think about. And then looking towards the left of the screen, that if that TTE is non-diagnostic, you still have suspicion, undergoing surgery, that TE should be moved to, and that's also a class 1 indication. And then kind of looking towards the bottom right of the figure is that you can kind of see how cardiac CT and FDG PET are creeping in, but we'll talk about that a little bit later. So in terms of looking at the historical performance, I should say, of echocardiogram in the evaluation of endocarditis, is that it does vary wildly amongst studies. And some of the reasons for that is that it could be related to pretest probability in each population can vary. Also, a lot of the gold standard used for confirming that this patient does in fact have endocarditis is usually at autopsy or explantation. And in those situations, the prevalence towards higher disease or more severe disease, sorry. There's a lot of confounding factors, such as devices causing a lot of artifact, and the echo imaging technology. Actually, a lot of these studies were done about 30 to 40 years ago, and our echo technology has changed quite substantially. But in terms of the performance of TTE or your surface study in the detection of endocarditis, is that for vegetations, it's about 50%, prosthetic valve abscesses, 30 to 50%, and then lead-related infections, RV lead, about 25 to 40%. And, some might say, I want to see these numbers higher, but it's still kind of a decent first look for the evaluation. And again, more to highlight for the same reasons that I mentioned earlier for access and cost, as well as the bonus that you get that functional assessment, particularly regurgitant lesions. However, if there's no evidence of endocarditis on the prosthetic material by TTE, ongoing clinical suspicion, the next best step is proceed with TEE. And that's also a class 1 indication on that AHA chart that we're looking at. And not so much here, but in the States, that they do kind of make a plug that in high volume echo centers where a lot of TEEs are being performed, that if you do have prosthetic material or prosthetic valve, that they do make a consideration to go for TEE as the first line test. But I mean, even from a practical standpoint here, that us getting our surface study is quite easy, but that's just a plug that they tried to make for it in this article. And to mention that the CIED stands for cardiac implantable electronic devices, which would include things like pacemakers and ICDs. So in terms of sensitivity for TE, that your TE will definitely be more sensitive than your TTE when you're trying to detect these cardiac abnormalities with infection. Most of this due to a higher spatial resolution, proximity to the probe, and a lower likelihood for imaging artifacts, although it's not completely free of artifact. And comparative studies show that TE is performing at about 90% for the detection of prosthetic valve vegetations, abscesses, and lead infections, which is impressive. And also studies indicate that TE should still be considered even with a low pretest probability to absolutely rule that out in the setting of prosthetic valve endocarditis. There is a bit of a hit to sensitivity, although not that much compared to native valve endocarditis, where TEE has sensitivity of about 99%. That's decreased to about 90% when there's prosthetic material involved. Structures that are not seen well on TE, like the anterior ring or the distal portion of the right ventricular lead, can run into a bit of issues. Although there's maneuvers that you can try to use to bring out the tip of the right ventricular lead. And then also just with other devices, if I know them kind of more towards the general, but when it comes to LVADs, there's a lot of different areas that can be infected, including the driveline, the pump pocket, inflow or outflow cannulas, which you won't be able to see all of this with your TTE or TEE. But echo is really great at revealing high-risk abnormalities that would push you towards an indication of urgent surgery, particularly that you have, now say severe mitral regurgitation, refractory heart failure. That's going to change your surgical timing. You get to see the size and mobility of vegetations, and then gives you kind of a sense of what the embolic potential of those vegetations, causing something like septic embolism, stroke, PE. And also to the advent of 3D echo, you have a chance to define the size, dimensions of very complex lesions. Just the image on the right from a TE study using 3D of the mitral valve, you kind of see this complex vegetation that almost looks like a whale's tail here. I don't know if you can see my mouse, but interesting that 3D does have utility there. And then also to echo allow you to monitor for lesion size, failure to reduce vegetation despite appropriate antibiotic therapy. So then maybe you're taking a course of 6 weeks of antibiotics, and that periodic monitoring of that can be done very easily with echo to say that we're reducing these vegetation size. But with the cardiac implantable electronic devices, pacemakers and ICDs, lead removal is recommended, although evidence that antibiotics alone could be considered that if your TE did not show any findings, which is interesting. So it would spare you the complicated extraction, especially if that device has been in situ for a long period of time. So specifically with prosthetic valve endocarditis, some of the things that you should be looking for is severe prosthetic valve dysfunction, regurgitation, or stenotic lesions, dehiscence of the valve, if you can see the valve is rocking, annular or aortic abscesses, and of course the presence of fistulas. Which is not surprising. There are more complications are more common with prosthetic valves than native valves. And even if you do have a positive surface study or TTE, TE is still recommended to rule out or detect high-risk features that could change things from a surgical planning or even prognostic standpoint. And that, particularly with these prosthetic valve endocarditis cases, is that's a very dynamic, changing course and can evolve very rapidly. And so in terms of a good monitoring tool, echo, again with access and cost, is a good tool to deal with this. So I know Abdul had a chance to talk about a lot of this, but just to kind of review some basic protocols that you want to be considering when you're doing a study for endocarditis. The best guidelines would be in the ASC, which actually do address this issue in its entirety, which is a little bit outside the scope of this review today, but definitely head to their websites if you want to check out that guideline. But importantly, you're assessing for regurgitant or stenotic lesions, rule out thrombus as well, as could be a mimic for vegetation, pannus formation, and then degeneration, particularly the valve leaflets themselves. It also gives you the opportunity to assess, especially if the gradients aren't making sense, high output states, prosthesis patient mismatch, and pressure recovery. The beauty of echo will also, and TE in this situation, allows you to conduct this assessment at multiple levels, planes, and then also using 3D. If you do see occult perivalvular regurgitant lesions, that maybe you should think about, could there be a fistula here? For the CIEDs in particular, they do make a plug for use of the long axis cable, bicable view for right-sided leads, short axis, multiplanar imaging, X-plane, 3D, and use of transgastric window. ICE catheters, which definitely seeing more of those. And ICE stands for intracardiac echo, and really kind of looks, and I should have included a picture here, but essentially it's a long, thin catheter where the tip of that catheter is the probe, entered usually through the right side of the heart. It is actually used in a lot of procedures, particularly when crossing the septum in interventional procedures. And it kind of looks like almost like a little lighthouse. And there is some emerging data that that ICE is at least as sensitive as TE for these CIED device-related infections or endocarditis, which I think is pretty interesting. I'm not sure it's going to take over, but it's just another kind of trick up our sleeves that we could think about. And then one of the other big things that kind of we've been focusing on these ICD or pacemaker leads as what's holding the infection, but also pockets, whether that be a VAD pocket or the pocket usually over the below the left clavicle, as that could be your source of infection. And typically with that, although not echo, still using sound waves, I can use non-cardiac ultrasound to see that if there's any abnormal fluid collections there, or assess the driveline site of a VAD. Now, there are some limitations of echo, specifically addressing the false negative interpretations. In the evaluation of suspected prosthetic valve endocarditis or the CIED infections, a negative result does not completely exclude the possibility of infection. And a lot of us in our reporting do state that almost in every study. Vegetations can be missed, particularly when they're small. If there's issues with the technical aspects of the imaging on your surface study, whether it be due to body habitus, short rib spaces, what have you, positioning, or you have a lot of prosthetic material in there, particularly if multiple valves have been replaced. Other issues is that with severe MAC and calcium buildup can hide annular abscesses. And also too early in the postoperative course, particularly with surgical valve replacements, it can be difficult to differentiate between edema, hematoma, and abscess. But one of the ways that you can try to get around this is the use of intraoperative TE, which can be used then to compare against future studies to show that if there's been an evolution of those findings. At least gives you a kind of a baseline to start with, as opposed to if you're just looking at it plain for the first time, that you may jump the gun for saying that this is endocarditis, when in fact it's just resolving edema or a small hematoma. With CIED and LVAD infections, not all components can be visualized, as mentioned before. And this is really just to highlight this kind of multi-modality approach, whether it be with ultrasound or other imaging modalities. And then into the false negatives, moving towards the false positive interpretations. And I mean, really this kind of is a point that fits for both, but the clinical context is very, very important. Because there can be a lot of findings on echoes. There's a lot of blips and things that may make you think, oh, what's that? But I mean, if your patient has no symptoms, blood cultures are clear, you don't want to necessarily call things that aren't really there, or that could be aseptic. And so some of those things could be non-infectious thrombi, although mortality in itself in another talk, but fibrin strands, pannus, or prominent endothelialization of sutures, particularly in surgical replacement. Edema and hematoma that I mentioned, or remodeling of the tissues early after surgery. And particularly with the CIED, I haven't seen too many of this, but I have read about it. But thrombus can definitely form along the lead. But what happens is there's this fibrinous sheath that encases the lead over time as it sits within the right ventricle. And then even after extraction of that lead, you can get what they call a lead ghost, because it still has that fibrinous sheath that's along the wall of the right ventricle. Visible masses on leads can be seen about 14% of TE studies, and the majority of these are non-infectious. So you got to be very, very careful not to invoke the diagnosis of endocarditis in these situations, because then that person is headed towards lead extraction. So moving on to our next imaging modality with cardiac CT. So particularly this can be very helpful and complementary to echo, but with specific situations in mind. CT provides a lot of good anatomical information regarding prosthetic valves, paravalvular extension, and assessment of anatomical relationships within the heart and around the heart. It also can help be helpful in the evaluation of mechanical leaflet excursion and its anatomy. And then you also get this extended visualization of the entire chest. All components of your CIEDs can be seen, as well as VADs. And what's kind of being pushed, and I've definitely started seeing this more within the TAVI population, is that you can perform a cardiac CT coronary angiogram. So that at the same time, you can have that assessment of your coronary arteries that's necessary before undergoing cardiac surgery. Because if you have blockages while they're in the replacement valve, they can perform single or multi-vessel CABG. So in terms of diagnosis and management with the use of cardiac CT, is that CT findings have actually been included in the diagnostic criteria for endocarditis. There's not a specific class recommendation for this, but I think it just highlights the importance of kind of using this as a complementary test. And just in the bottom right-hand corner, you can see just an excerpt from the ESC, where they talk about, as a major criteria for definite endocarditis, of CT. And I don't want to jump the gun, we can also see FDG PET kind of sneaking its way in there too. The diagnostic accuracy data is limited between native and prosthetic, and it's usually because it's a mix of both. But there was this meta-analysis that was conducted in 2015, looking specifically at prosthetic valves. So they looked to see how CT would perform using TTE and CT versus TE, and the sensitivity of periannular complications was 100% with TTE and CT as opposed to TE alone. But the specificity was similar, 94% versus 96% in those groups. And then in terms of trying to detect vegetations, as a similar performance, sensitivity 82 versus 88%, and specificity 96 and 94% respectively. So kind of you see a little bit more usefulness when it comes to assessing for abscesses or periannular complications. There's another meta-analysis that was done actually fairly recently in 2020, where it examined 8 studies, CT versus TE in native and prosthetic valve endocarditis, and compared that based to what the intraoperative findings were. And you know, the CT actually performed really well, identifying about 78% versus 69% in TE, and that's at a p-value of 0.052, so almost significant, borderline significant, if you will. So take that for what that is. But TE definitely had a higher sensitivity for the detection of vegetations, 94% versus 64%, and just extremely positive. Multi-phase studies can be very helpful with CT. Abscess detection was similar amongst the two. And specificities between the groups was also similar. Just something to make you think about. And then prosthetic valve endocarditis, there's another study done in 2020. A very small sample size, using only 15, but showed that CT was superior to TE to detect pseudoaneurysms, and equivalent for vegetation detection in abscesses. And also adding CT on top of your echo can increase the number of detected mycotic aneurysms that altered patient management in up to 25% of patients with suspected prosthetic valve endocarditis. So, and definitely don't get me wrong, I'm not trying to make a plug for CTs to replace echo, because I'm preaching to the wrong group here. But you know, something that can be complementary to your study, and also too that if there's any complications with the TE from a procedural aspect, that CT in the setting of working kidneys can be very easy to obtain, particularly these days. So CT with CIED and VADs is that it still can be quite challenging. Imaging of the SVC and radiatrium can be difficult due to inhomogeneous contrast enhancement. There's a lot of swirling artifact and shadow, and so particularly when you're looking at pacemakers which occupy mostly the right side of the heart, that there can be this difficulty in visualization. However, large vegetations can definitely be seen, although it is difficult to differentiate from thrombi, or again, this tissue growth, that fibrinous sheath. Generator pocket can be well visualized. You can see collections of fluid as well as stranding, which would suggest an inflammatory process going on there. And I have some images coming up of kind of what this looks like, but if you've seen any CT contrast or not, that there's significant artifact with these kind of dense streaks or kind of shimmering light that project from the metal within the device, which can kind of hide things underneath it. LVAD, you can see the driveline very well, and also abscesses can be detected. And CT, I mean, even if you're definitely headed down the course of surgical intervention, that most surgeons will want a CT. as there's to get a better understanding of the specific anatomical extent of your pathology. Surgical planning, maybe you have to replace place an aortic graft. Do you have time to get an aortic homograft? Although I know it's very expensive. And then, as I mentioned kind of before, coronary CT as an option as opposed to invasive angiograms. Don't tell the interventionist I said that, but there are some studies that are looking specifically into this, which show it has a high diagnostic accuracy in patients undergoing elective valve surgeries. However, you have to kind of consider that it's not a perfect test, particularly in older adults. If there's a lot of calcium buildup, that there's no point doing the angiogram portion of the CT because the radiology will just send you back. And also too, that if there's a lot of hemodynamic compromise. So you're worried about endocarditis. This patient population can typically be sick. And one of the problems with coronary CTA is that you need to be at relatively low heart rates. When I did my CT MRI rotation, the amount of IV beta blocker being pushed into some of our heart failure patients almost stopped my heart. They use an aggressive amount of it because they need to be at slower heart rates to be able to see things better. But so maybe that may not be possible to provide significant doses of beta blockers to these patients as they're already so sick. And then of course, too, CT is very helpful with if that they've already had a previous sternotomy, if they're going back in, and to know graft locations. So to be careful that if they're cutting back into the chest, that they have a better understanding of where all your grafts, lemas, and vein grafts are. So just some extra images. So on kind of the top left, the contrast CT of the heart, right ventricle on the top, followed by the left ventricle, and you can see this.
I'm using a phone.
You can see this giant arrow sign here. That's pointing at a large vegetation that's along a pacemaker lead here.
I think when the BM window is connected, it will happen automatically.
And in the kind of talk about that streaking artifact that many of you have probably already seen. The CT below, you can see that artifact that's being generated by the
I think this was straight internet university.
Can of the ICD, which obviously can shield everything below it. And then the internet itself also kind of showing that.
About the same.
Or streaks.
Please mute yourself if you're not speaking. Thank you.
And so, and moving forward, that even with these CTs, it's looking at a mechanical aortic valve, non-contrast on the left, contrast on the right, and which can help, especially with these surgical pledgets that are along the valve border, is that, in other studies that may look like, oh, that's related to possible infection, or with these contrast enhanced images, you can actually see that they're just pledgets from the surgery itself and not abnormal or inflammatory or infected tissue. And then kind of looking at some more cases of CT and endocarditis. So the image A in the top left of your screen. So this is a bioprosthetic aortic valve with a pretty large vegetation there. Image B, also another bioprosthetic valve, but where you can see those asterisks is formation of abscess. That's between the aorta and the RVOT. C, mitral valve, also see that large vegetation, which the arrow is pointing to here. And then moving to D, this is a mechanical valve with where the asterisk is a large mycotic aneurysm. And then where these tiny little arrows are actually just pledgets. That's actually not part of the infection, but it's this kind of big area around here. Then E, another kind of example of something similar, mechanical valve with a mycotic aneurysm, almost at the origin of the takeoff of the RCA. And then F, you can actually see complete dehiscence of this mechanical aortic valve almost coming completely free from the wall of the aorta. So moving on to our next imaging modality, FDG PET and nuclear imaging. So in the infection process, infections associated with an increased accumulation of immune cells. And these cells express a high level of glucose transporters that uptake this FDG and can be, signal can be imaged with PET. Now, migration of these cells occurs actually very early in the course of an infection before there's any clinical evidence that this infective process is going on. Echo and CT can detect these morphologic changes, but can be equivocal. However, FDG PET CT can provide confirmatory information that can really help you clinch that diagnosis. So, specifically looking at diagnosis of device-related infections, that there's a meta-analysis done looking at CIED infections, which showed a pooled sensitivity of 87% and a specificity of 94%. And that was done back in 2017. And when it came to prosthetic valve endocarditis detection, performed at sensitivities ranging from 73 to 100% and specificity of 71 to 100%. And then with LVADs, it can help accurately localize the site of infection, particularly along your driveline or the central portions of the VAD. It does typically, in the literature, have a high sensitivity, but the specificity can be quite variable. And FDG PET can detect perivalvular endocarditis before both T and CTA have detected the anatomical damage that's been done as a consequence of that infection. So it can really provide some upfront data. And this is kind of an example of this. This is a case that was presented in the article where it was this gentleman, I believe was in his 70s, previous history of a mechanical aortic valve, which you can kind of see in slide A here. And as we're not reading a lot of CTs, this is essentially a normal study. But he had presented with malaise, feeling unwell, and fever, was admitted to hospital, and then was found to be growing multiple bottles Staph aureus, which is obviously a very invasive and one of the most dangerous microorganisms for endocarditis. So he's admitted to hospital, and they perform this CT, which, and in this slide A, can't really see much. They then went to perform an FDG CT PET, which here in these kind of highlighted kind of purpley areas, as were high FDG uptake, which were suggestive of significant early infection / inflammatory process. Because of the findings of this PET, the patient was actually taken to surgery for exploration. And as you can see, trying to take a look at the valve, is that they actually couldn't really see anything. So I don't know if they went back and said, hey, look, your PET scanner is broken, but we can't really see anything. So the patient was sent back to the wards, continuing with antibiotics. However, the patient's course worsened. There was persistent positivity of the blood cultures, was not clearing. So they repeated the CT, the cardiac CT, and now this time you can actually see the formation of a mycotic aneurysm here. Same patient, 8 days from the surgical exploration. Echo, you can see a large abscess here. And then when they went back for repeat surgery, now you can see it's almost completely different picture with abscess formation, pus, and extremely hostile friable material. So again, just kind of highlight how important PET is in the early detection of infection. And is there any way that we can improve Duke? So adding FDG PET in the evaluation of prosthetic valve endocarditis as an additional major criterion to the modified Duke increased the diagnostic sensitivity from 52 to 70%, specificity 91 to 97%, which is huge. And it can definitely take your diagnosis of possible endocarditis and make it definite if you want that slam dunk. And that was seen to be similar for pacemaker ICD related infections. So really it's just trying to make you think that if you kind of fall into ruled out possible definite endocarditis, that there is this push to suggest that you should be performing FDG PETs based off the modified Duke to kind of increase, especially in the specificity. PET's also very good. It can be a whole body scan, able to detect other infectious foci, like your primary, that's outside of the heart or chest. So that you lit up a part of the spine that could have been related to osteomyelitis, say, and can also identify septic embolism events. So in the bottom image here, you have FDG PET. Arrow is pointing, the solid red arrow is pointing at abnormal uptake along the right ventricle. Sorry, it's kind of a small picture, but if you can imagine the way RV bead would kind of travel here, that it's right in that position. And then where the arrow with the clear center, that's a big uptake within the right lung, which is related to a large septic embolism that he had. You kind of see the changes on CT here that increase FDG there. So, as many of you are probably thinking, well, it can do both infection and inflammation, infection being septic and inflammation being aseptic. So I don't want to be tricked into thinking that maybe it's an inflammatory process there that's not related to infection. So some things you can use is look at the pattern of your FDG uptake. Typically, it will tend to be very focal in the instance of an infection, and typically more homogeneous along inflammation sites. Focal FDG of high intensity likely represents infection. However, intensity has not been shown to be reliably differentiate itself from inflammation. So more focal, but not necessarily more high intensity. And there's different units that nuclear uses to define that. The ESC actually put out a statement that they do not recommend PET within 3 months of the implantation of a device, given these features of a bunch of non-specific uptake, just because they don't want to be fooled, or advising not to be fooled. That's there could be early changes, particularly after surgery. But other studies have been done since then, and this one actually more recently in 2020, as a prospective study that looked at non-infected prosthetic aortic valves, and that imaged them at 5, 12, and 52 weeks, and showed this low to indeterminate diffuse uptake throughout all those times. So just saying that, waiting, this is probably what it's going to continue to be like, but the difference is maybe related to surgical technique, the device material itself. There's also particular adhesives and glue that can cause more uptake. And then, which I thought was interesting, the anti-calcification material on those on bioprosthetic valves can also have more FDG uptake. So just being aware of this, that anti-calcification material is called alpha amino oleic acid, and can create false positives. And in this study that they found that even those changes will persist up to 1 year. And that's just due to the technology of the valve itself. So other things they try to do to improve the differentiation between infection and inflammation is to use bacteria-specific PET radio tracers that can actually target specific microbes or physiologic similarities against microbial species. So, for example, one of those is called the maltodextrin transport system that is not present in mammalian cells, so won't light up with us, but will for staph, for example. And then they use 18-fluoromaltohexose, and it's actually used to detect early CIED pocket infections. Nuclear alternatives. So white blood cell scans, probably heard, but what they can use is radio-labeled white blood cells, or gallium-67 citrate, which is an iron analog, which plays an important role in transferrin and the inflammation pathway, and is also used by microorganisms as necessary material for survival. So a lot of uptake within infections, bacteria, I should say. Both are less sensitive than FDG, but more specific. So it depends exactly what kind of question you're trying to ask to solve your clinical question. But these scans are widely used for patients if you have fever of unknown origin, which can be very frustrating, and is used quite consistently in actually prosthetic joint infections. The problem with white blood cell scan specifically is it's very labor intensive. Preparation takes a long time. The injection, you have to wait 24 hours before you can rescan. So that it does kind of create a little bit of a dilemma, especially if you don't have that kind of time. And then also spatial resolution for these scans is not as good as FDG. But if your FDG was equivocal, that this is something that you could use, so you can think about that. And then white blood cell scintigraphy or the white blood cell scan has been validated for both native prosthetic valve and CIED related infections, as well as vascular graft infections. So really, what's FDG bringing to the table? Well, it can diagnose early infections, and really what I think is, for me anyways, is one of the best features is provide that confirmatory information in equivocal cases. Also, you can improve the performance of your Duke criteria. And then of course that if you didn't have a really clear understanding of where your infection source was, that you can use this to find out, where that is. And then of course, septic emboli. So in terms of, what the authors of this paper were trying to push is just create some flowcharts about how to deal with these certain types of infections, which is pretty similar to what the ACC/AHA guidelines would say. But if you ever have a prosthetic heart valve infection that you're suspecting, always start off with your Duke criteria, TTE, TE, and blood cultures. And then just to remind you with the rejected, possible, and definite criteria. So with Duke, to have a definite 2 major criteria, 1 major, 3 minor, or 5 minor. Possible endocarditis, you have 1 major, 1 minor, or 3 minor criteria. And then rejected, you have an alternative diagnosis, resolution less than 4 days after antibiotics. But then following this flow chart, that even if you have that slam dunk, I definitely think this is prosthetic valve. Well, do you know where your primary source is? Consider FDG. Or I want to know that if there's any perivalvular extension, I want to assess my coronary anatomies, consider your CT. And then possible, where I really think it's kind of useful, is enter this kind of loop here, but well, I don't know, I need to kind of take my equivocal diagnosis and make a definite FDG or CT. And then if those aren't working, you could also consider a white blood cell scan. And then these are just kind of 2 further kind of algorithms. So looking at specific CIED infections and VAD, both everyone's starting, no one's taking echo away, always very important. But then again, just highlighting that FDG PET can be very helpful in, again, just trying to tease this out if mostly that you're unsure. Okay, well, thank you so much, everybody. I know that was a lot of endocarditis the last 2 weeks, but thank you all for listening and getting questions.
So thank you, Jeff, and for this comprehensive review. And it's also great that you're mentioning about all the comprehensive or complementary way of actually assessing endocarditis using CT as well as FDG scan as well. Can you comment on our access to FDG scan in Toronto or Ontario in general?
Yeah.
Where can we do it?
Yeah, so that's one of the biggest problems, because it's a different kind of environment than the American healthcare system, but our access to PET is really quite limited. Not only are the scanners very expensive, but the radioisotopes are extremely expensive and require centrifuge labs, and then also high volumes. So the government has actually said that, you know, it wants to try to limit the number of PET centers. Toronto is one, but there is a scanner at Toronto Western and Princess Margaret. And then Ottawa also has another big program. But the problem is that all of the PET requests have to go through Ottawa. So when you're ever filling out those forms, it's going through Ottawa and it's heavily vetted about whether or not the indication is necessary. And, you know, when you see a lot of this, is that, you know, maybe you're getting through some recommendation or approvals for myocarditis or sarcoidosis, for example, but it's otherwise they're very stringent. So I know that it'd be really great that if we had better access, because I mean, even with this, that if you're really unsure, it should be used, but access for us, unfortunately, at the moment is still limited.
Yes, indeed. I think I heard about FDG a number of years ago, and especially advocated by our European colleagues, because I think in Europe they have much more access than we do. So first time I heard is actually from France, and but then again, and then when we come back to Canada, it's like, oh, where can we get it? And then I think the last conversation I had was Toronto Western, and then we had to vet through Dr. Ivanishko, and I think now it's Ottawa.
Yeah, exactly.
Chi-Ming?
Yep.
Yeah, so in fact, St. Michael's is in the middle of procuring a PET CT. We received the funding through significant donation with plans to have it installed in 2023. We're working on the infrastructure for that, and also with the ministry on the capacity for cardiac applications for PET CT. So it should be a bit of a game changer for us.
That's very
that's
exciting.
wonderful news. Any other questions or comments? And just incidentally want to mention that our upcoming Canadian Cardiovascular Congress in October will be in Ottawa. And the highlight or the spotlight event for Canadian Society Echo will be actually on endocarditis. So we'll learn even more about endocarditis from all the colleagues from around the country. It speaks to the importance of this topic about, you know, all the multimodality imaging of it. Well, without further ado, we'll give back 3 minutes to your day, and then, you know, enjoy the beautiful sunshine and also the wonderful warm weather of 22 degrees outside.